We are going to discuss about kidneys and urinary tract. Before going into the topics, we need to have basic idea about the anatomy of the kidney. So kidney is a bean-shaped organ. It weighs about 150 grams in males and 135 grams in females. It is a retroperitoneal organ and covered by a fibrous capsule, thin fibrous capsule, and this capsule is adherent at the hilum. Hilum is a structure located in the medial side of the kidney in which renal artery, renal vein, ureter, all these structures open into the renal hilum. So next, blood supply of the kidney. Renal arteries supply the blood to kidney. So on cut surface of the kidney, it has cortex, medulla and renal pelvis. And nephron is the basic structural and functional unit of the kidney. So there are millions of nephrons present in the kidney, both the kidneys. Nephron word is a Greek word which means kidney. Now we are starting about glomerulonephritis. Glomerulonephritis is a subset of renal diseases in which there is immune mediated damage to the basement membrane and mesangium and endothelial cells of the capillaries, which leads to proteinuria, hematuria and azotemia. Azotemia meaning increase in the blood urea nitrogen levels. So coming to etiology of the glomerulonephritis. In etiology we have two types, infectious causes of glomerulonephritis and non-infectious causes of glomerulonephritis. In infectious causes it is due to beta hemolytic streptococcus organism. In non-infectious causes it may be due to primary renal diseases or hereditary diseases or vasculitis and malignant hypertension, that means very high blood pressure. Students, we have to learn about RPGN, which means rapidly progressive glomerulonephritis. That means the clinical features of these glomerulonephritis progresses very rapidly. So it is a clinical diagnosis, it is not a pathological diagnosis. So based on the etiology, RPGN is divided into three forms. One is anti-GBM RPGN. Anti-GBM meaning anti-glomerular basement membrane antibody, which is seen in systemic diseases, and next is post-immune type, and next is immune complex type. In immune complex type is post-infectious RPGN. Types of glomerulonephritis. In this we have acute glomerulonephritis and chronic glomerulonephritis. In acute glomerulonephritis, clinical features are started suddenly on sudden onset of hematuria, proteinuria and azotemia. In chronic glomerulonephritis, it is a long-standing inflammation which leads to scarring of the kidney. That is chronic glomerulonephritis. Clinical features of glomerulonephritis. In this we have foamy, cloudy urine. Due to proteinuria, urine becomes cloudy and foamy. Next is cola colored urine. Cola color is due to RBC present in the urine. Next, high blood pressure and fluid retention, fatigue, malaise, all these are clinical features of the glomerulonephritis. Coming to lab diagnosis of glomerulonephritis, in this we have to see complete urinary examination for increase in the RBC, presence of erythrocytes in the urine, and RBC Cas or increase in WBC in the urine, because in infections WBC are present in the urine. Next, urine culture to identify the organism growing in the urine in cases of any infection. In blood test, we need to check for serum creatinine and blood urea nitrogen, and we need to check for serum complement levels and serum ANCA antibodies and anti-GBM antibodies, ultrasound KUB and X-ray KUB and kidney biopsy. These three are also done in this glomerulonephritis to see any change in size of the kidney. Coming to pathophysiology of glomerulonephritis, so suppose in post-infectious glomerulonephritis, antigen comes in contact with antibody, it forming antigen-antibody complex. This antigen-antibody complex is deposited in the glomerulus. In this deposit proliferates the epithelial cells of the glomerulus, and then it leads to again leukocyte infiltration in the glomerulus, then ultimately it leads to thickening and scarring of the glomerular filtration membrane, resulting in decreased GFR. So coming to gross pathology, in acute glomerulonephritis, the kidneys are bilaterally enlarged 1.5 to twice the size of the normal kidney. And external surface and cut surface, we see petechial hemorrhages giving the appearance of flea-bitten kidney. Coming to microscopy, glomeruli are enlarged diffusely and hypercellular. Hypercellularity is due to proliferation of mesangial cells, endothelial cells of capillaries, and occasionally epithelial cells. There is also infiltration by leukocytes such as neutrophils, monocytes is also seen. There is small deposits of fibrin seen in capillary lumina and mesangium. Hyaline droplets are seen in tubular cells and tubular lumina, and there is interstitial edema and leukocyte infiltration. Coming to electron microscopy findings, in electron microscopy there are irregular hump-like deposits along the epithelium of the glomerulus, and in immunofluorescence we see irregular deposits seen along the GBM, and these irregular deposits mainly consist of complement C3 and IgG. So next, morphology of the chronic glomerulonephritis. Grossly the kidneys are smaller and granular, contracted kidneys we call it, and next in microscopy we see hyalinization of glomerulus. So our next topic is pyelonephritis. Pyelonephritis definition is inflammation of the renal parenchyma and renal tubules. So etiology of the pyelonephritis. Etiology of the pyelonephritis includes infectious causes, gram-negative organisms and gram-positive organisms. In gram-negative organisms, we have Proteus, Klebsiella, Enterobacter, and in gram-positive organisms, Staphylococcus saprophyticus, Staphylococcus epidermidis, and Enterobacter, Corynebacterium. So these are the organisms which cause pyelonephritis. Next, coming to clinical manifestations. In this we have mild pyelonephritis in which low grade fever is seen and CV angle pain. CV angle pain means costovertebral pain. Next, severe pyelonephritis. In severe pyelonephritis we have high grade fever, picket fence fever, and nausea, vomiting, flank pain. In lab investigations we should do urine microscopy to observe appearance of WBC and urine culture to identify bacteria growing in the urine, and imaging studies we can do CT kidney urinary bladder. On gross pathology, we can see wedge shaped suppurative areas on the kidney and focal abscesses. So on cut section, we can identify varying areas of hemorrhage, necrosis, and can palpate the crepitus, and we can see gas filled cysts in the renal papillae and renal cortex. The renal capsule is detached and filled with the blood clot, which is called as subcapsular hematoma. Now coming to microscopy of this pyelonephritis, in microscopy we can see neutrophilic infiltration and exudative inflammation, neutrophilic infiltration in the cortex and tubular lumina. In emphysematous pyelonephritis, we see hemorrhagic and necrotic areas and scattered gas-filled cysts are seen.